let's move to the last topic, which is imaging of CNS toxicity in pediatric cancer treatment, which will be presented by Professor Hye Kim. Professor Hye Kim, she is a professor working at the Samsung Medical Center, Sangkunwon University School of Medicine, Seoul, Korea. Please welcome Dr. Kim.
Thank you, speaker. Sorry. Good afternoon, everyone. It's my great pleasure and honor to be here and greatly appreciate for the organizing team of the RCRT-RST this year and the AOSR for inviting me to this wonderful congress. Today, I'd like to review on the imaging of CNS toxicity in pediatric cancer treatment. These are the list of subjects. I will review the CNS toxicity according to the treatment options and other problems. Let's start with the radiation-induced brain injury. RT-induced brain injury can be classified into, excuse me, can you enlarge the images? Sorry, I cannot see the images, so it's too small. More, please. Thank you. Thank you. Sorry. The RT-induced brain injury can be classified into acute, early delayed, and late delayed reactions. The acute parenchymal lesion is quite rare with the conventional dose fractionation schemes, so usually nothing can be found on MRI. Early delayed reaction, we can see the pseudo-progression with a T2 hyperintensity and enhancement. Late delayed brain injury can occur more than 6 months after irradiation, which is mostly irreversible. Because there is an increasing number of the long-term survivors of the pediatric oncology patient, we are increasingly faced with these long-term complications, which include leukoencephalopathy, RT necrosis, diverse vascular disorders, and secondary tumors. The post-radiation treatment effects can be divided into the pseudoprogression and radiation necrosis. It starts with endothelial damage and consequent tissue hypoxia and the disruption of the blood-brain barrier. It usually occurs with a daily fraction more than 300 centigrade with larger intracranial lesions. The steroid is used for both prevention and the treatment. The tumor pseudoprogression is defined as increased lesion size simulating progressing disease. Because there are many overlaps between the pseudoprogression and RT-related necrosis, it is not incorrect to say that pseudoprogression is a mild and self-limiting variant of the RT necrosis. It is commonly seen in both chemotherapy and the RT was performed rather than RT alone. The patient usually presented with less than 3 months after the treatment, ranging from first few weeks to 6 months. It depends on the radiation dose, and most frequently seen in patients with a methylated MGMT gene, especially who underwent temozolomide treatment. Eventually, the pseudoprogression, the decreased tumor size and the resolution of the enhancement can be seen. This is a representative case. We can see this thalamic glioma, and after irradiation, we can see the increased extent of the T2 hyperintensity and the increased enhancement. But on follow-up, the tumor size decreased with the decreased enhancement. So this is a pseudoprogression. So we have to differentiate active viable tumor progression and the pseudoprogression, and this is a summarized table. The tumor progression usually occurs outside the radiation field later after the treatment, but pseudoprogression can be seen within the irradiated areas and earlier. Diverse typical findings of the viable tumor, including the increased cerebral perfusion, low ADC values, high choline peak on MRS, and increased methionine uptake on PET, are not seen in pseudoprogression, or the reverse is true. The patient condition is deteriorating in patient with a tumor progression, but stable in pseudoprogression. This is a representative case. Embryonal tumor occurred in the right temporal lobe with increased T2 and enhancement and increased methionine uptake. In addition, we can see the tumor spread through the ependymal lining into the parenchyma with enhancement. The perfusion image shows a slightly increased perfusion that is similar to the cortical gray and apparently increased methionine uptake. This is a tumor. So this patient underwent irradiation and presented with acute symptoms after 5 months of the radiation. During the event, we can see the very extensive T2 hyperintensity here with increased enhancement and decreased perfusion, and there is no methionine uptake, suggesting it's a radiation effect rather than the tumor spread. How about midline glioma again? Tumor with the T2 hyperintensity, enhancement, slightly increased ADC values. But in case there is no increase in perfusion, but the methionine uptake is seen in this PET. After irradiation, there is extensive T2 hyperintensity here with increased enhancement, of course, increased ADC values, and there is no decreased perfusion and decreased methionine uptake, so it is comfortable with the RT effect and the tumor progress. However, this tumor eventually really spread, so compared to the prior findings, we can see the increased T2 hyperintensity, increased enhancement, but increased ADC values too. Again, decreased perfusion, although there is a prominent methionine uptake. So the diffusion-weighted images and the perfusion images oftentimes not so helpful in the midline glioma. Radionecrosis is decreasing with the neuroprotective protocols of irradiation. However, depending on the total dose, daily fractions, and individual sensitivity, RT necrosis should be taken into consideration when making diagnosis. The imaging findings are very similar to the viable tumor, but the RT necrosis shows hypometabolic on PET or SPECT and decreased perfusion on perfusion images. However, even these advanced techniques do not always differentiate tumor from RT necrosis. This huge ATRT was resected, and there is another enhancing mass here on follow-up images after RT with some edema, but decreased perfusion, and there is no methionine uptake, suggesting it's an RT-related effect. And the follow-up image shows this enhancing region became encephalomalacia, so suggesting RT necrosis. The leukoencephalopathy is the most frequent complication in long-term survivors with T2 hyperintensity white matters, say sparing U fibers, which is subsequently followed by the ventricular enlargement and the cortical atrophy. There are a variety of vascular complications associated with irradiation, which lead to increased risk of stroke years after the irradiation. Let's see the individual cases. This is a craniopharyngioma. The only partial resection was possible, so RT was performed. And on follow-up images, we can see various steno-occlusive lesions at both proximal MCAs and the distal ICAs, suggesting RT-induced vasculopathy. In this patient with a neuroblastoma with dural metastasis, RT was performed. On follow-up, you can see very small T2 hyperintensity lesion here, and a tiny dark signal intensity dot suggesting hemorrhage. This region became larger with repeated bleeding and eventually became typical popcorn-like appearance. RT-induced cavernous malformation. How about this hemorrhagic mass in the patient with medulloblastoma? This mass is seen with surrounding edema suggesting recent bleeding. There is another subependymal nodule here, very difficult for the tumor seeding. And methionine PET shows increased uptake for this small tumor. For this hemorrhagic mass, there is a photon defect with the surrounding background, mild activities. So both of the lesions were removed, and the small one was reported to be a medulloblastoma, and the second, the hemorrhagic mass was RT-induced cavernoma was suggested. Do you agree? Yes. However, on follow-up, we can see the increased enhancement at the resection margin, and the methionine uptake is noted at the surgical defect, suggesting a presence of a viable tumor. So sometimes it's very difficult to differentiate. The mineralizing microangiopathy can occur in the basal ganglia, gray-white junction, and dentated nucleus. It is easily seen on CT, but very difficult on MRI, so we have to look for the dark signal intensity like this at the typical location on gradient or SWI. In this particular patient with medulloblastoma with stroke-like symptoms who underwent irradiation, we can see the very subtle enhancement here. And involved area shows darker signal intensity of the white matter and the mild diffusion restriction. The perfusion increased here, and there is a strong methionine uptake raising concern of the recurrent tumor. However, these MRI findings disappeared after 4 weeks. On MRI, we can see the engorgement of the distal branch of the left PCA, which was reduced on subsequent follow-up images. So I suspect it should be a SMART syndrome, an acronym for stroke-like migraine attacks after radiation therapy. SMART syndrome is an uncommon delayed complication of the cerebral RT, which occurs more commonly in boys. It is believed to be the exacerbation of the post-ictal phenomena due to prior RT, and frequently seen in patients who received the cerebral irradiation more than 50 gray years later. There should be no tumor, and the symptoms referable to the irradiated cortical area, including the seizure and migraine-like symptoms. The typical imaging findings include gyral swelling with enhancement, transient minor diffusion restriction, and regional hyperperfusion suggesting transiently impaired autoregulation. It is believed to be radiation-induced endothelial damage and vascular dysfunction, usually self-limiting, but incomplete recovery or permanent imaging sequelae were also reported. We have to exclude number one, recurrent tumor, and subacute stroke, familial hemiplegic migraine, and so on. The steroid and the anti-epileptic drug is used for the treatment. Let's move on to the chemotherapy-induced brain injury. Many chemotherapeutic drugs can cause neurotoxicity with diverse spectrum of clinical findings. The risk factors include those combined RT and chemotherapy, genetic background, but there is unknown pediatric patient predilection. The leukoencephalopathy is a potentially serious complication of chemotherapy. It is particularly true for the regimen that includes methotrexate. However, there are many other drugs that can cause white matter injury. During the acute phase, we can see the white matter lesion with a diffusion restriction without enhancement. This is a typical case of MTX-associated leukoencephalopathy, we can see nothing or very faint T2 hyperintensity, but there is a strong diffusion restriction at both the centrum semivalley. Very similar findings of white matter regions are seen in this patient who received a regimen that include cytarabine. And we can also see the splenium lesions with a strong diffusion restriction. In this patient with leukemia with very high risk factors who received the tyrosine kinase inhibitor treatment, and there was increased level of the ammonium. So under the impression of the hyperammonemic encephalopathy that was performed, we can see multiple white matter lesions with a diffusion restriction. Could it be hyperammonemic encephalopathy? Let's review the reported cases. Hyperammonemic encephalopathy is known to present with extensive bilateral cortical and the thalamic swelling with a diffusion restriction quite different from these findings. So we can assume that it could be chemotherapy-induced leukoencephalopathy, especially for the cytarabine and intrathecal MTX. In patients with PNET with leptomeningeal dissemination, we can see extensive T2 hyperintensity white matter lesion here, even involving the U fibers, and there are multiple T2 hyperintensity lesions with some enhancement. The perfusion decreased except for the enhancing area, and there is no significant methionine uptake. This tiny uptake is a residual seeding tumor. So these findings are typical for the disseminated necrotizing leukoencephalopathy called DNL. On later follow-up images, we can see the dilated ventricles due to extensive white matter loss. So DNL is more severe in the fatal form of leukoencephalopathy, originally described in children with ALL treated with high-dose MTX and RT. The extensive white matter changes, T2 low signal intensity foci, and enhancement are typical findings. This morning, Elaine reviewed the press, and I will show you that these diverse chemotherapeutic agents also cause the press with a typical clinical presentation. And additionally, there is an increased seizure susceptibility by anti-cancer drugs. This is a case with diffuse midline glioma who underwent chemotherapy. We can see low density of the white matter here, which is more prominent in the posterior part of the cerebral hemispheres. Similar findings can be seen on MRI with increased ADC values. And interestingly, the involved areas shows increased perfusion. Vascular disorders can occur with chemotherapy, ischemic or hemorrhagic with anti-angiogenetic drugs, venous sinus thrombosis by the L-asparagine, and vasculitis. This patient received L-asparagine treatment, and we can see, very high density sinus and its tributaries, so on pre-contrast CT, very similar to the post-contrast images. So pre-contrast CT is very helpful to see the presence of a thrombus in the venous sinus. And the gradient image shows dark signal intensity blooming, and post-contrast image shows we can see multiple filling defect in the superior sagittal sinus and right transverse sinus. There is accompanying the cerebral edema and the diffusion restriction and the multifocal hemorrhagic foci suggesting venous infarct. In this patient who were treated for the secondary AML, treatment of 8 years of neuroblastoma and diagnosed to have a GVHD, presented with stroke. On diffusion-weighted images, we can see numerous small infarct that distributing right cerebral hemisphere and the basal ganglia. So MR angiography was performed. We can see the missing right middle cerebral artery here. And more MRI shows increased signal intensity of the right MCA on proton density images, which was replaced by the strong enhancing or thickening, replacing the rumen. Additionally, we can see the basilar artery and both ICA were thickening with enhancement, suggesting vasculitis. Eventually, the brain impact progressed with massive cerebral edema. There are other complications, including cerebellar syndrome and myelopathy. This diffuse glioma patient underwent chemotherapy, and follow-up image shows cerebellar atrophy. The intrathecal MTX can induce spinal cord toxicity, which is very similar to the subacute combined degeneration of the spinal cord with a normal level of vitamin B12, because it involves the dorsal column, which shows inverted V or kangaroo ear sign on transverse T2 axial images. This is my patient. Initial MRI shows multiple enhancing tumors at the cord surface. And after treatment, including intrathecal MTX, extensive cord swelling and enhancement can be seen. And actual images, we can see the dorsal column is more severely involved with some enhancement. And the follow-up image shows cord atrophy with the residual abnormal signal intensity. The chimeric antigen receptor T cells are newly used immunotherapy for treatment of B-cell malignancies, and it is increasingly used for the pediatric patient too. The CAR T cells significantly elevate inflammatory cytokines. So the adverse events are classified into 3 categories: cytokine release syndrome systematically, and immune effector cell-associated neurotoxicity syndrome, so-called ICANS, and the HLH and the macrophage activation syndrome. So I'd like to show you the ICANS. ICANS is a CAR T cell-related encephalopathy, which can increase the inflammatory cytokines that finally resulting in the CNS inflammation. ICANS occurs concomitantly with the CRS, and the severity appears to be associated with the severity of the CRS. The patient usually presents within a week after the CAR T cell infusion with diverse clinical symptoms. This is a reported case. We can see multiple leptomeningeal enhancement and cortical cytotoxic edema like this. And additionally, we can also see the microbleeding and the progressed cortical lamina necrosis. This is our case. This girl received the CAR T cell infusion after induction failure of the B-cell leukemia. On day 2, this symptom presented, and clinically CRS grade 2. There are multiple small or subtle T2 hyperintensity parenchymal lesions and microbleeding foci, as well as some cytotoxic edema of the gyri. So with this clinical background, I suspected it should be ICANS. Let's move on to the surgical complications that include parenchymal damage, hemorrhage, embolism, and hypertrophic olivary degeneration. This huge ATRT was resected at outside hospital, and this patient referred to our hospital under the impression of rapidly progressed tumor. We can see multiple enhancing parenchymal lesions here with the T2 hyperintensity just 2 weeks after surgical resection. So I doubt it should be a parenchymal lesion rather than the tumor spread, because it's a too short period. The embryonal tumor usually spreads through the CSF space, that is the brain surface and along the ventricular lining. And eventually the follow-up image shows multifocal tissue loss, suggesting parenchymal lesions. In this patient with a relapsed ATRT, we can see the tumor bleeding here at the surgical defect. So hematoma evacuation was performed, but another bleeding occurred even in the ventricles. So this hemorrhage caused vascular spasm, resulting in the massive hypoischemic encephalopathy. So uncontrolled bleeding continued. So extensive brain edema was occurred. In this patient with medulloblastoma, immediate postoperative MRI shows parenchymal injury and hemorrhage, and follow-up images show bilaterally swollen inferior olivary nuclei, which was shrunken almost 2 years later. So this is hypertrophic olivary degeneration, which was caused by the lesions of the cerebellum or brainstem, which can disrupt the triangle that connects red nucleus, dentate nucleus, and olivary nucleus. Very unique pattern of the transsynaptic degeneration. Metabolic and nutritional disorder can occur in cancer patient. In this patient who was diagnosed to have a gut GVHD, presented with acute encephalopathy, we can see very subtle hyperintensity at the medial thalami and the periaqueductal areas and mammillary bodies, which was normalized after the treatment. So this is a typical Wernicke encephalopathy. Wernicke syndrome can occur due to diverse nutritional problems of the cancer and its treatment. A typical location is a clue for the diagnosis. Because the patient became immunocompromised due to cancer itself and the treatment, opportunistic agent can cause infection. I will show you a couple of cases. This is a patient with leukemia and cryptococcal meningitis. We can see multiple coalescing gelatinous pseudocysts in the both basal ganglia along the perivascular space without significant enhancement and some diffusion restriction, which may be due to thick cyst content or acute infarction due to vasculitis. Another patient with leukemia and aspergillus infection, we can see reminiscing nodules with massive edema. Lastly, I'd like to talk about the diverse tumors. Metastasis is the most common neurologic complication of the systemic cancer, which usually occurs gray-white junction and watershed areas. The meningeal spread is another important route of spread. Of note, the CNS relapse of the neuroblastoma can occur with bleeding into the CNS, even without clear relapse signs on both imaging and clinically. So, this is a CNS relapse of neuroblastoma who was initially have a dural metastasis, and follow-up image abruptly shows hemorrhagic mass here. Another patient shows hemorrhagic mass. Another patient also shows multiple hemorrhagic masses. So if we see any hemorrhage in the brain who are treated with neuroblastoma, we should consider CNS relapse. PTLD can occur in the brain after transplantation, and in this patient we can see the midline mass with edema and a strong ADC decline. It was proved to be diffuse large B-cell lymphoma and improved after rituximab treatment. Radiation also induced secondary neoplasms, which occur within the radiation field at least 3 years after the radiation. This is a last representative case who was treated for the retinoblastoma during the infantile period. And we can see the thymus. This was proved to be pleomorphic sarcoma, another basal ganglia tumor. It was a glioblastoma. So in summary, the CNS is very susceptible to complications of systemic cancer and its treatment. In addition to the conventional treatment modalities, newly developed immunotherapies also associated with significant neurotoxicity. So we have to recognize these imaging patterns of toxicity for prevention of the further injury and differentiate treatment-related regions from the treatment tumor. Lastly, I'd like to invite you all to the silver anniversary AOSPR, which will be held in Doha, Qatar. Thank you for your listening.